today's topic is urinary tract infection. It's not a very good topic for theory discussion, but it has got tremendous importance in the clinical practice. And it is considered the most common bacterial infection in human body. That is why it has taken a special importance in your teaching session. I don't want to start the presentation in a typical way. Suppose if you look at the presentation, you will see that a 45 years old lady presented with lower abdominal discomfort and increased frequency for 3 days. Increased frequency of urine, nothing else. She is also complaining of vaginal discharge. She is recently diagnosed diabetic. She is perimenopausal with irregular periods. With this small history, I am showing it now. I will also show you at the end of my presentation then what is your conclusion about this patient. So any of you who is sitting at the last bench, can any of you say what is your preliminary idea about this condition of a patient? Any idea? What she is having? Say, any of you say boldly. You cannot commit. Okay. Then I'll have to start from the beginning that this lady is a typical presentation. If you go to the medical ward, if you go to the surgical ward, if you go to the gynecological ward or the endocrinological or the urological ward, this kind of patient you will get almost every day. At least 1 in 10 patient you will get with this kind of a presentation. So we are going to start the urinary tract infection. What comprises the urinary tract? In kidney, ureter, bladder, urethra, and in male, especially prostate and the accessories gland like seminal vesicles. This comprises urinary tract. In female, the prostate and seminal vesicles are absent. You know definitely the reason, because the reproductive organ in female is totally different that of the male, and its origin and the correlations are also different in case of the male. That is why those organs are not present in female. As I have told you, the urinary tract infection is the most common part, the most common infection, bacterial infection in the body. It can be divided into a specific infection and the non-specific infection. We are mainly dealing with the non-specific infection. The specific infection like tuberculosis will be dealt in some other class. It actually a bacterial invasion. In some cases it can be fungal infection, and in case of fungal infection, the situation is totally different. Mostly the patients are immunocompromised. That is why that is also not considered in today's lecture. We will consider mainly the normal patients, those who are having urinary tract infection. Urinary tract infection is basically inflammation of the urinary tract with the bacterial invasion. Most commonly it involves the bladder, which is called cystitis, and it also involves the urethra, that is urethritis. It can also affect the kidney, that is called pyelonephritis, leading to severe complications. So 3 terms I am telling you, remember this, you will have to remember rest of your life. One is urethritis, one is cystitis, one is pyelonephritis. Pyelonephritis means the inflammation of the kidney. Cystitis means the inflammation of the urinary tract, and urethritis is the inflammation of the urethra. In case of male, there is one organ more, that is called the prostate, that is called prostatitis, which is not considered in today's lesson, and also seminal vesiculitis, which present with normally you will not understand, blood in the semen. That is the presentation of the seminal vesiculitis, which I am not considering. So 3 things is very important. Remember the names, and this also you should remember. The urinary tract infection is most common in female. Why it is most common in female? Any idea why it is most common in female? And if it is in male, we'll have to take a special consideration that this patient is harboring a severe other anatomical or the pathological conditions related to it. So in male urinary tract infection, when you get a patient with male urinary tract infection, you should always remember it is not a solitary infection only. It is usually associated with other obstructive symptoms, other obstructive cause, or other congenital anomalies. This is totally reverse in case of the female. That is mostly due to the anatomical configuration of the female genitalia and the coexistence of the urinary system close to the genitalia. What happens? Male urethra is 20 centimeter long and it is totally separated. On the contrary, female urethra is only 4 centimeter long and it is absolutely in conjunction with the vagina. If you remember, this is the genitalia, this is the anus and this is the urethra. So what happens? Whenever a person, lady especially, they have the habit of washing from below. They wash the anus after defecation from below. What happens? The water containing bacteria, stool always contains bacteria. So these bacteria containing fluids enters the vagina. These bacteria containing fluid enters the vagina. Understand? And what is vagina? Vagina is a long muscular tube with lots of, in a reproductive age group, lots of secretions from the vagina takes place and bacteria grows over here. Bacteria grows over here. Because of the short urethra, any liberation of the vaginal discharge from here, what happens? It enters the urethra and urethra is only 4 centimeter, and it contains the bladder is out here. So once the bacteria comes here, it gets a very short tract and entered the bladder, and bladder is full of water and nutrients. It works as a reservoir and culture media for the urine. That leads to a last bench. Please concentrate. If you don't like, you can leave. So this is the acts as the reservoir, and special importance I am telling you. I will tell you the details which bacteria is responsible for the most of the urinary tract infection. But first to get the concept why the female are more prone to infection. Bacteria has got, if that is the bacteria, they have got certain pili, they have got certain point at the surface of the bacteria. And the epithelial cells in the bladder, they are also having some receptor on it. These bacterial pili get attached to it. These bacterial pili gets attached to it. So what happens? It gets permanently or for a long time, they get attached to this mucosa, and when the concentration of the bacteria increases a certain level, that is in clinical practice we consider is 10 to the power 5, more than 10 to the power 5 colony forming unit. 10 to the power 5 colony forming unit, if it crosses, it produces a clinical presentation. That is why the female are more prone. It is not the fault of the female. It is some kind of personal habits and the God's creation which has made the female population more susceptible to the urinary tract infection. Now I have told you the what kind of organisms are taking place in causing infection. You will have to remember one bacteria, that is E. coli. E. coli comprises nearly 75 to 85% of the urinary tract infection. I will consider the special condition little later once I get the full idea about the urinary tract infection. So E. coli is the most common, followed by Klebsiella, and in complicated cases you will have to remember Pseudomonas. So 3 bacteria, all of are Gram-negative bacteria, these you will have to remember rest of your life. Whenever you select the treatment, always consider at the back of your mind, it is the E. coli. It may be something else otherwise, but don't forget E. coli as the main concern for the infection. We can see E. coli is 53, but it is a different data. Main data is 75% plus. And least important is the Staphylococcus aureus. But I will tell you how the bacterial entry takes place. Once I have told you that bacterial entry takes place mostly from ascending tract. From outside, genitalia and the urinary tract is open to outside, so bacteria enters from outside. That is the ascending infection. Ascending pathway is the most common way by which the invasion of the bacteria, invasion of the urinary tract by the bacteria takes place. But what other routes can take place? That is the hematogenous route. By how hematogenous route? It is mostly by Staph aureus. In case of very severe condition, we get a urinary tract infection by hematogenous spread. Tuberculosis is one of that situation in which the infection takes place by hematogenous route, and other condition is in diabetes mellitus, especially those who have skin rashes, skin infection. From the skin infection, the bacteria enters the urinary tract through hematogenous route. I will tell you the difference in the site, how it takes place. I told you at the beginning, it is the most common bacterial infection worldwide. Highest incidence in female, that is the 50% at least experience one episode of urinary tract infection in their lifetime. Risk factors are female sex, sexual activity, pregnancy, diabetes, use of catheter, and urinary tract abnormalities. These I have told you before only, that these are the predisposing conditions which leads to a susceptible lady or a man for urinary tract infection. What is recurrent UTI? One patient, especially it is applicable for the female. She has come with urinary tract infection. We have treated her seriously over 3 weeks or 4 weeks. She is fine. Within 2 weeks, she came back with another episode of infection. So by definition, in a one calendar year, if a patient, female patient, suffers from more than 3 times, remember, in a calendar year, if a patient suffers from more than 3 times, it is called recurrent urinary infection. How does it differ from the reinfection? Recurrent infection is taken place by the same bacteria, same genome. You all understand what is genome, what is the bacterial sequence, all these things you must have read in microbiology. This I am not going into detail, but this thing you will have to remember. If it is done by the same bacteria within a span of 3 to 6 months, it is usually recurrence. On the contrary, reinfection is usually by a separate group of bacteria which leads to the infection, but on subsequent investigation we will find a separate genome and a separate bacteria as a causative agent. Now, how do we classify the urinary tract infection? There are many classifications in the textbook, but you will have to remember the current classification, which is very practical classification based on clinical presentation, risk factor, and severity. Clinical presentation, I will come now. What is clinical presentation? How the patient has come to you. I have given you a story at the beginning of the class that a 45 years female came with such and such problems. That is called clinical presentation. And we will have to see how severe it is. I mean, the patient is having just symptoms which can be managed in the OPD treatment, or patient needs admission. This severity assessment is a clinical assessment, which I will tell you what are the symptoms in the clinical assessment. And third is the severity, how severe it is. Whether he needs oral antibiotics or he needs IVI parenteral antibiotics, whether she needs further evaluation or it's a simple evaluation in this case. And in this reference, I don't want to forget one thing I am telling you, there is a very common short note. What is honeymoon cystitis? Honeymoon cystitis is normally taken place after the marriage, which is an uncomplicated urinary infection, which you should remember, and this can come as a short notes. So, what are the types of infection then take place? One is asymptomatic bacteriuria. The patient may come with bacteriuria with no symptoms. That means the bacteria are present in the urine but no symptoms. That is called asymptomatic bacteriuria. Second group is symptomatic urinary tract infection. Most commonly it is cystitis. Most commonly it is inflammation of the urinary bladder, which is called cystitis. But as I told you, as the severity of the condition improves, the condition when the only bladder is involved, it is cystitis. When the kidneys are also involved, that is called pyelonephritis. And when it has become a generalized infective disorder related to the urinary system, that is called urosepsis. These are the terms you will have to remember rest of your life. Not very important for examination, but this is very important for your day-to-day work. So these three terms you should not forget. One is cystitis, one is pyelonephritis, another is urosepsis. I will tell what is what. So this is the clinical diagrammatic presentation. What is called what? When the kidney is involved, it is pyelonephritis, good. When the ureter is involved, it is called urethritis. When the bladder is involved, it is called cystitis. When the urethra is involved, it is called urethritis. Urethritis. In case of male, prostate is involved, prostate, that is called prostatitis, and seminal vesicle is involved, it is called seminal vesiculitis. So this is the total picture out of which the demarcation, the upper ureter and the kidney comes into the upper tract, and this is the lower tract of the mainly, which is the most commonly day-to-day practice we get in the as a urinary tract infection. This you need not know. Now the pathogenesis. Pathogenesis, I have told you. Normal urethra has some colonization. Those are not infective organism. That means that is the colony forming organization. Lactobacillus, we have seen many a times we give lactobacillus to the patient. Why? In the gut, that is the common commensal. Similarly, in the around urinary tract, there are few bacteria. They are not infective to the patient, but they reside. Around the external genital tract. Then I have told you that uroepithelial penetration. Here I have told you how the pili has invaded the receptor in the urinary tract bladder wall, and they get stuck to it and liberate different kind of inflammatory substances from the urinary bladder mucosa and leads to urinary tract infection, clinical urinary tract infection. Next is upward movement of the bacteria from lower part to the kidney. This is I have already told you pyelonephritis, and the most important and the dangerous situation which I have not mentioned till now is AKI. AKI is acute kidney injury. There may be total shutdown of the kidney. Kidney may stop producing any urine, and the serum creatinine will increase along with electrolyte dyselectremia. Dyselectremia may take place. These are the very serious condition, and the mortality rate is more than 30%. So don't take urinary tract infection if it crosses the lower limit. That means if it becomes pyelonephritis, you should not take it lightly. You always remember pyelonephritis is a very serious condition and patient needs admission in this case. Two special situations I will have to mention. One is the pregnancy and another is emphysematous pyelonephritis. What is emphysematous pyelonephritis? Emphysematous pyelonephritis is the inflammation of the kidney with production of air inside the kidney. Have you ever heard of it? Emphysematous pyelonephritis? Good. It is mostly in diabetic patient. It affects mostly, I will show you the picture. One patient is right now admitted under me with pyelonephritis. I will show you the real picture of that patient. These produces internal necrosis. It produces internal necrosis of the renal parenchyma and gas forming organ E. coli, mostly the common affecting agent that produces gas inside the kidney. The importance of it, that it is a very serious condition and mortality is more than 30%, and it may require removal of the kidney if we cannot control the infection with medication. The primary objective of treating emphysematous pyelonephritis is the drainage of the kidney, either by double J stent inside or by percutaneous nephrostomy, which drains the kidney, allows the kidney to drain and remove all the infected material outside. But if it is not done, or in spite of giving broad spectrum antibiotic and the drainage, mortality is still 20 to 30% of the patient, and 30% cases will require nephrectomy ultimately to save the life of the patient. That is why the emphysematous pyelonephritis is a very important condition. It can come as your short notes. Emphysematous pyelonephritis. Next condition I am telling you, the pregnancy related UTI. We all know, have you done the gynae obstetric clinic? Have you done this? Okay, you have done this. What is the protocol? In the first visit and the last visit before admission or confinement, there must be urine examination. Because in pregnancy, even the asymptomatic bacteria also needs attention. Why? The mortality rate of in the peripartum time, mortality rate of the newborn increases. Mortality rate of the newborn increases if the female is affected, mother is affected with urinary tract infection. Why pregnant women are prone to infection? Number one, that is, there is excess of progesterone in the body that produces a slow peristalsis of the urinary tract. That is, the ureteric peristalsis will be slow. Number two, the gravid uterus is compressing over the urinary tract. That is also causing your delayed drainage. Main condition why the urinary infection takes place. Urinary infection takes place in spite of the bacteria. If the drainage is good, the bacteria cannot stay. Any condition which leads to the delayed excretion of the urine, either from the kidney or expulsion of the urine from the bladder, can lead to the urinary tract infection. In the this case, in the pregnancy also, these are the conditions which need special attention. If the mother is having asymptomatic bacteriuria or positive symptomatic bacteria, they should be treated aggressively to prevent any further fetal loss. So these two conditions are of immense importance. You should remember it for your examination. I have told you all these things. Pathogenesis is mainly the ascending route, and bacterial proliferation of the inflammation of the symptoms. Severe cases, bacteria ascends to the kidney, pyelonephritis, leading to sepsis. This I have told you. Now comes the clinical feature. Symptoms of the cystitis is mainly, you will get, I don't know, any of you have the experience of urinary tract infection or not. It's a very troublesome situation. Apparently, urinary tract infection appears to you nothing, is nothing, one dose of antibiotic will cure. But that is not the fact. Fact is, it has a long-term consequence. it has a long-term consequence. To prevent the long-term consequence, we must treat the bacterial infection in a patient who is suffering from urinary tract infection very seriously. The symptoms are mainly dysuria, that is painful urination, increased frequency of urgency, suprapubic discomfort, and hematuria. These are the symptoms for the cystitis, that is the lower tract. But when symptoms of the upper tract takes place, which I have told you the severity increases, is the fever and chills, flank pain, nausea, vomiting, and costovertebral angle tenderness. What is called the renal angle tenderness. These are the four things. If you see in a patient, admit her. Admit her immediately, because these are the patients will turn into very serious condition where the treatment requires very aggressive mode to save the life of the patient. You cannot take this group of patient lightly, so that the patient suffers to a bigger casualty. Now comes the diagnosis. How will you diagnose a urinary tract infection? First is history taking. The clinical presentation, that is the examination. This I have told you, these are the what history the patient gives and what examination we will have to do. We will have to see whether the patient is any features of the upper tract involvement, whether there is patient is having any obstructive voiding symptoms, whether the patient has large amount of residual urine, whether the patient is having any stone obstructing the systems. These are the things you will have to rule out when you are dealing with a suspected case of urinary tract infection. The gold standard is urine analysis to diagnose the urinary tract infection, that is the pyuria, presence of WBC in the urine. Newer tests have come. All of you have read about it in bacteriology, that the nitrate test is positive in the gram-negative bacteria. These are the deep tests. You can do it. Leukocyte esterase test indicates WBC presence, because leukocytes liberates these enzymes. And third, and the gold standard, is urinary culture. How do you do the urinary culture? It should be midstream urine. It should be midstream urine. Not necessarily it has to be the early morning urine or the first urine of the day. It's a wrong concept. A patient is infected only in the morning, not in the other part of the day. So any time of the day, but the midstream urine is very, very essential to collect the specimen, because we need to wash the urethral commensal before we collect the specimen for urinary tract infection. And third is, if there is complication we are suspecting complication, that is upper tract involvement, we will have to think of other imaging modalities, that is ultrasonography, CT scan mainly for the kidney involvement, obstruction or abscess. As I have told you, the stone can create an obstruction that leads to the formation of the infected fluid and leading to abscess formation. There may be infected hydronephrosis. There may be pyelonephrosis, that is passed within the urinary system. So when you are assessing a patient, if the severity is high, not only the lower tract symptoms, then you will have to go for this evaluation to assess the patient in totality. Now it's very important, you will get urine culture report with multiple bacteria invading the as the causative organism. Do you think that's a proper culture? That is faulty technique of collection. That is called contamination of collection. Normally, urination is a monobacterial infection. So if there is multiple bacteria found in the culture, you must remember you will have to repeat the culture or find out what is the importance of it. And it is very critical number of uropathogens is 10 to the power 5 in general, but you will have to remember certain conditions. If a patient like diabetic patients who is suffering from the recurrent UTI, in her case or his case, even the 10 to the power 3 colony forming unit is of great importance. Third thing is in male, even it is 10 to the power 4, that requires adequate attention, because I have told you in male the urinary tract infections are never ordinary uncomplicated urinary tract infection. These are usually complicated urinary tract infection which needs special attention and evaluation to rule out what is the major cause of creating this urinary tract infection. This I have already told you, that asymptomatic bacteriuria. What is asymptomatic bacteriuria? What is acute uncomplicated UTI? That is the lower tract symptoms. Third is complicated UTI, that is the upper tract symptoms, and the recurrent UTI. All four things I have discussed. These are the things you will have to remember in your clinical practice. I am telling you, this class will help you if you take it into your mind, not in your notebook, because you will need it rest of your life, that when the patient comes, you will have to classify the patient, categorize the patient, so that they get the proper management, whatever subject you do. Now comes the treatment. Treatment complicated UTI. First line is nitrofurantoin, fosfomycin, trimethoprim. Don't start with unnecessary ferropenum. Don't start with unnecessary third generation cephalosporin to treat uncomplicated urinary tract. I will tell you why. Yes, that is the reason. Bacterial stewardship and antibiotic stewardship, this I will discuss. Antibiotic stewardship and the bacterial resistance are coming as a menace. That time will come, maybe from 10 years, you will not find a single antibiotic to treat a patient of simple urinary tract infection, because all will be resistant. So use antibiotic very precisely based on urinary tract culture. This I will discuss later on. Complicated UTI, that is when we suspect pyelonephritis, that is fluoroquinolones, IV antibiotics, ceftriaxone, piperacillin, tazobactams. These are the antibiotics to be given for the treatment of bacterial aspect only. But at the same time, we will have to find out whether the patient is having other associated clinical situation which needs attention. Suppose the patient has come with a large stone in the ureter with obstruction. By giving only antibiotic, you cannot treat the patient. You will have to drain the kidney. If you want to drain the kidney, what will you do? Either you will have to put a double J stent to drain the kidney, or do a percutaneous nephrostomy. By giving only antibiotic, you cannot save the patient. And recurrent UTI, I have told you the prophylactic antibiotic. I will tell you details with stories only, because if I tell you like this, you will not remember. And behavioral modification, I have told you, washing from front, post-coital voiding and washing, and personal hygiene. These things are very, very important in prevention of recurrent urinary tract infection, and prophylactic antibiotic may be given in selective cases. How? That few women, they usually come to you with the urinary tract infection. If you take history, that within 48 hours she had a sexual activity. These may lead to recurrently urinary tract infection, recurrent episodes. So we advise them to take post-coital single dose of antibiotic, so that she does not get this bacteriuria adequate to produce this infection. So these are the prophylactic antibiotic in selective cases, and behavioral modification, that is hydration, hygiene, post-coital voiding, and washing from front, not from back. So this is the outline of the treatment for the urinary tract infection. I have told you already that maintain good personal hygiene, stay well hydrated, urine frequently and completely, wipe from front to back. This is another important thing. It is the very common Indian practice to pour a gulp of water in the genitalia after passing urine, in females especially. What happens? That allows a moist environment. If you don't wipe that water, That water trickles from here to there and they allow the bacteria to invade, they allow the bacteria to ingress. So always keep the genitalia dry and wipe from above below. Wipe from above below, not from below above. Any condition, your hand should not go up, hand should go down. What is love? Love is actually the blessing from above. So always remember, to save you, you have to put your hand from above below. And he was telling the antibiotic resistance. You know what is the prediction? Prediction is after 2036, if this kind of irrational and irregular antibiotics are used, surgical branch may collapse. The surgical branch may collapse if we are not judicious about the use of antibiotic. I think these all are discussed in microbiology. I don't want to go, but still I am remembering you. It's a very important thing in treating the urinary tract infection, because urinary tract infection is the most common infection, bacterial infection, which needs antibiotic use. This is more applicable for the ICU related patient, where the very high-end antibiotics are used and the bacteria in the surroundings are mostly resistant to most of the common antibiotics, those we are using nowadays. And the importance of the antibiotic stewardship, I just mentioned one line. Why antibiotic stewardship is important? Every hospital should have their antibiogram, and according to the antibiogram we should use the antibiotic. We should not use antibiotic of our choice. I like this antibiotic, this company people have told me this is a very good antibiotic. No, this cannot be the criteria of selection of antibiotic. You will have to maintain the protocol of the hospital to use which antibiotics are used, because these protocols are created by taking the culture pattern in at least 1,000 patients of that hospital to find out which antibiotics is most susceptible and use that antibiotic. Keep other antibiotics at your hand for future. Now I have told you the story. At the end, I have shown you this story before. Now one of you stand up and say, 45 years old lady, lower abdominal discomfort and increased frequency 3 times a day. When she has come with this, what important thing has come to your mind? You stand up and say, first wait. Yes. What do you think? Use this. Everybody should listen to it. Use this.
Sir, it might be a case of UTI or lower abdominal discomfort, or some pelvic inflammatory disease can also be there, and increased frequency for she is of vaginal discharge. So she is postmenopausal and she is also diabetic, so she is immunocompromised. So pseudomonas infection can also be there. Some pseudomonas infection, because she is sending a vaginal discharge, so we have to see the color of the discharge. If green, then most probably pseudomonas infection.
You won't get this kind of a thing very frequently, green color vaginal discharge. Anyway, you just carry on. Good.
And she is also having irregular periods, so she is postmenopausal, irregular period. Perimenopausal. So she is suffering from irregular periods. So for this, we will first we have to manage the patient for this.
So she is thinking, he is thinking that a lady has come with suspected urinary tract infection. So what are the things you will do? What you will ask? Apart from the history you have got, what you will ask to the patient? That is very important. You tell me what you can ask. You tell me. I am asking you, man. What, yes, you. Acha, you tell me. What do you ask? You tell me, stand up, tell me. Tell me, what extra information you want to have from her? Good. Anything? Recent sexual activity. recent section. Don't hesitate. It's a clinical condition. You'll have to take this history from the patient. And third, yes, what is the type of the vaginal discharge? That you will have to ask. Sit. So, I am telling you a story. One very, I don't want to name her, one lady came to me with recurrent urinary tract infection. She has already visited 3 senior urologists of the city. Everybody offered evaluation, radiological evaluation, antibiotic. But none of them have examined her. None of them have examined her. On examination, we found she is having a small infected Bartholin cyst. Small infected Bartholin cyst, which is flaring up maybe once in 2-3 months for 2-3 days and discharges bacteria from there, and she is getting the infection. Why I am telling this story? The reason is clinical examination has immense importance. Never hesitate to examine the genitalia. Never hesitate to examine the genitalia. Never hesitate to examine the suprapubic region. Never hesitate to examine the back, that is the renal angle. Also take a detailed history. What is the voiding pattern? Whether the voiding is free or the voiding is obstructive, whether the patient is needing any help. Maybe she's getting up 3 times at night, and every 2 hours, 1 hour, she's going to the loo, but she's not emptying her bladder. So these are the important things you must take into consideration when you are getting this kind of a patient. Then what will you do? We have taken clinical examination that she is not having any of the presenting symptoms. Then you can tell her, make her understand the importance of prevention, how we can prevent. I told you how you can prevent advise the patient how you have to prevent it. Number 2, if there is positive findings, suppose her renal angles are tender, she gives, yes, last night I had a chill with rigor. What will you do? You must evaluate her thoroughly. You must give urine culture. You must give total count. Also the blood sugar and renal function test. Also the blood sugar and the renal function test you must give. Then you have to advise on ultrasonography to rule out any anatomical abnormalities present or not. So anatomical abnormalities rule out, presence of infection, clinical findings, all these things together. If you get the result, you will come to know whether it is an uncomplicated UTI or a complicated UTI. If it is a complicated UTI, admit the patient, treat the patient seriously, as I have told you, IV antibiotic, drainage of the system, everything you will have to do. And third, there are certain conditions I have told you, you have to be very careful. The patient is diabetic. Whether it is recently diagnosed or late diagnosed doesn't matter. But diabetic patient with urinary tract infection is very, very vital. I am showing you a patient is admitted with me right now. Can you see anything? It's a CT scan of this patient. Can you see anything in this CT scan? Dilated ureter. Where do you see the ureter? Ureter is not the significant cause. What I want to show you two small dots. Anyway, can you see this? Can you see this? What is that? It's a black spot inside the kidney. What is this? It is air. It is emphysematous pyelonephritis. There is another picture. You see here, there is air. This is emphysematous pyelonephritis. There is one more. Yes, this small one there. Can you see this small tiny dot? That is there. But come here. It is the big club shaped calycial collection of air. That is emphysematous pyelonephritis. All these things, if you see, you will have to think, you will have to start parenteral antibiotics, you will have to start thinking of drainage the system. He said something very significantly, the ureters is dilated. This patient had a small stone in the ureter, lower ureter. This patient has a small stone in the lower ureter. Can you see? She's a diabetic patient and he has a stone in the lower ureter. If you don't drain the system, whatever antibiotic you give, ultimately you are not going to cure this patient. So always have a holistic approach when you are treating a patient. And why I am showing this picture, you will understand what happens to this lady. This is the isotope renogram. Isotope renogram, DTP isotope renogram will tell you the functional status of the kidney. Within 3 weeks time, the split function test, left side is 98.1% and right side is 1.9%. That means what? Kidney has become totally necrotic mass. It has got no function. It has got no function. So it is such an important condition. If you don't take it seriously, you don't remember, this patient is going to lose her kidney. I will do the nephrectomy next week. So that is the reason, that is the importance of taking the urinary tract seriously. Any question from any of you? Yes. Split function. This is the glomerular filtration rate, 98.1 milliliter per minute, which is the normal glomerular filtration rate. But this is the combination of the right side and the left side. It is the combination of the right side and the left side we consider the total GFR. When we divide it, then the side which is the more functioning will be demonstrated and the less functioning will be demonstrated, because this state in nuclear medicine you have not studied actually. So that is why try to understand there is the nuclear study of the renal function test which gives us the idea about the functional status of the kidney. Understand? This is very important in many aspects of the renal surgery, like hydronephrosis. Whether we, I think Anand will take the hydronephrosis class next week. That time I think Anand will tell you, Dr. Anand will tell you exactly what is split function test, how we differentiate a functioning kidney with a non-functioning kidney, up to what percentage of the split function test should we reconstructed the system, and above what function we should, below what GFR we should go for nephrectomy. These are the things Dr. Anand will tell you next day. Any other question from anybody? No question. So all of you know everything. Good. So if you don't have any question, then I will tell you a small story. Otherwise, you will never remember this system. In 1960s, you know, Rabindranath died. What was the cause of his death? Any of you know? Any of you know? What? None of you know. You know Rabindranath at least? Yes, but you don't know why he died, how he died. He died of prostatic obstruction with severe urosepsis. prostatic obstruction with severe urosepsis. He died of, he denied operation, only forcefully suprapubic cystostomy was done on him, which also, as I have told you, the days are coming that the common bacteria cannot be treated with normal antibiotics and the surgical department will be jeopardized. The bacterial resistance. That time we had only penicillin with us and the bacteria were resistant to it and we lost the great poet of our life. So remember, urinary tract infection is a very important topic for your day-to-day clinical practice. You will see many of your family members are getting this infection and they need proper evaluation and the treatment so that they can prevent the future complications. Okay? So that ends. My next class will be on renal stone. So I like to know what kind of class do you want? Do you want a discussion on the common topic or do you want a practical demonstration? What surgery we do, how the surgeries are done, what are the recent advances in surgery, what kind of class do you want? Practical oriented. You want to see what is pyelolithotomy, what is nephrolithotomy, what is present day PCNL, what is ureteroscopy, what is cystolithotrypsy, what is flexible ureteroscopy and laser lithotripsy. These are the things at the treatment part. I will stress more on the treatment part. So be prepared with the theoretical aspect. What are the clinical symptoms? What are the types of stones? How the stones are formed? What are the predisposing conditions leading to stone formation? How the stones are analyzed? How we can prevent, because renal stone is a recurrent disorder. Once a stone former is always a stone former because the biological changes cannot be altered most of the time. So once a person has developed a stone, he has the chance of developing further stone within 2 to 5 years. So these are the things you people read. I will ask you and then I will start the current management of the renal stones and how it should be done and how it should be prevented. Okay?